Good morning everyone. This is Dr. Asbar, Department of ENT Assistant Professor. Now with the continuation of the last class, we are going to discuss a very important topic, that is chronic suppurative otitis media, which is atticoantral type. Okay, let us see why it is atticoantral and what are the features and how it presents and management options. It is a chronic infection of the middle ear cleft, lasts more than 3 months, with cholesteatoma and granulation tissue in attic or posterior superior quadrant of the pars tensa. It is called as unsafe type, or it's a dangerous type because it is associated with higher chances of complications like meningitis, intracranial and intertemporal complications like facial nerve palsy, etc. What are the complications? In subsequent classes you can know, and it is associated with high chances of complications. That's why it is called as unsafe CSOM. And most important, the hallmark of the disease is either cholesteatoma or granulations. So what do you mean by a cholesteatoma? Let us see. Okay, before that, actually this is not the definition. The proper definition of the cholesteatoma is, the term cholesteatoma is given by John Muller in 1858, and it is defined as a three-dimensional sac. It is lined by a matrix of keratinized stratified squamous epithelium that rests on a thin layer of fibrous tissue and contains a desquamated keratin debris which grows at the expense of surrounding bone. This is the definition of the cholesteatoma. You have to produce as it is in a case of exam. Okay, you have to write as it is, right? And oma, any oma, you can think of a tumor, but it is not a, though it is a cholesteatoma, it is not a tumor. Okay, so you can say better as it is a skin in a wrong place. Middle ear, you don't have stratified squamous epithelium, right? Keratinized stratified squamous epithelium is a hallmark. I mean, this is for skin, right? So you can't see a squamous epithelium in the middle ear. So the cholesteatoma in a simple word is skin in the middle ear, means squamous epithelium in the middle ear. Okay, so skin in a wrong place. So it is also called as skin in a wrong place, and the better term is also, it is also known as epidermosis. But here the important point is, it has a line of keratinized squamous epithelium which is on the fibrous layer, and it is like a sac, and in that sac it has a desquamated debris. Okay, so how it looks like? See this is bone, right? And this is fibrous stoma, the second layer, and this is stratified squamous epithelium. You can see cells are arranged in a very disciplined manner, stratified squamous epithelium, and this is like a sac, right? This is like a sac, and all these debris, okay, the keratin debris, the middle one, you have a keratin mass, the accumulated keratin mass you have. So it is like a sac. Okay, so why there is a bony erosion? Why it erodes the bone means the following mechanisms are most important. One is hyperemic decalcification. It decalcifies the bone. Okay, and the next is osteoclastic bone resorption. With the activation of the osteoclast, it causes bone erosion. Why osteoclasts are activated? By means of few enzymes like acid phosphatase, collagenase, acid proteases, proteolytic enzymes, leukotrienes and cytokines. The first, second are most important. Okay, with these enzymes it causes erosion of the bone. Okay, so the third one is pressure necrosis. It causes it keep on expanding. The sac is filled with a keratin debris, and the sac is keep on expanding, and it causes necrosis, pressure over the surrounding bone. And the fourth and final, least bothered about this one, is the bacterial toxins. Okay, the secondary infection which gives toxins, and it causes bony erosions. So these 4 are important. The first 1, 2, 3 are very important. These are the much frequently asked MCQ question in the pre-PG entrance. And what is the classification of the cholesteatoma? It is, one is congenital, the second one is primary acquired, third one is secondary acquired, fourth one is tertiary acquired. It is less frequent and it is frequently post-traumatic. Okay, so you should remember 1, 2, 3: congenital, primary acquired and secondary acquired. Okay, what is congenital cholesteatoma? Okay, so congenital cholesteatoma is, it arises from the embryonic epidermal cells rests in the middle ear cleft. During the development, there are few squamous epithelial cells, they entrapped in the middle ear. They later on they give rise to cholesteatoma. Okay, so they occur most commonly in the middle ear, petrous apex and cerebellopontine angle, and produce symptomology according to the site. Okay, for example, if you have a cholesteatoma in the cerebellopontine angle, you have various different presentation like dysphagia and multiple cranial nerve palsies. Okay, so there is one criteria called LEVENSON criteria which explains the congenital cholesteatoma. Okay, the criteria should be like, there is a white mass behind, medial to normal tympanic membrane, normal pars tensa and pars flaccida, no prior histology of, no prior history of discharge from the ear, or there should not be any perforation. And the fourth one is, there is no prior otologic procedure. And finally, prior bouts of otitis media were not grounds for media exclusion as it was the case in original definition. Means there might be some exceptions. There might be some otitis media and which also, we should not exclude it. So these 5 points are very important for the criteria. They might be asked. Can you see the normal pars tensa, and there is this arrow mark shows a normal white tympanic membrane. Behind it there is a white mass which is congenital cholesteatoma. Okay, acquired cholesteatoma, there are few theories which explains this cholesteatoma. The first theory is invagination or retraction pocket theory, which is given by Whitmack. Okay, Whitmack, what he says, due to persistent negative pressure in the attic region, okay, means behind the pars flaccida, there is a retraction pocket, means the tympanic membrane or pars flaccida is retracted. Into that retracted pars flaccida, there is a accumulation of keratin debris, epithelial squamous epithelium, which is from external artery canal. It accumulates in that invaginated tympanic membrane. Okay, so it leads to formation of the cholesteatoma. So Whitmack, that is the Whitmack, he says due to persistent negative pressure, means there might be a eustachian tubal dysfunction also behind this negative pressure. Okay, due to this negative pressure, the attic region, it forms, it converts into a retraction pocket which accumulates keratin debris and later on cholesteatoma. Okay, can you see this? Due to here, this is the tympanic membrane, this is the attic region, this is pars tensa, right? This is pars flaccida. Due to persistent pressure here, it forms like a retraction pocket. Here in second diagram you can see there is a formation of retraction pocket and it leads to accumulation of the keratin debris here. Okay, and second most theory is basal cell hyperplasia, which is given by Rudy. Okay, what Rudy says, due to hyperplasia of the basal cells in the epithelial layer, and they forms as, due to its subepithelial tissues, in a simple term, there is a proliferation of the basal layer of the pars flaccida, and it might be due to some childhood infections. And then this expanding cholesteatoma, it cut off from this region and it and it forms in the attic region. Okay. So the only one point in basal cell hyperplasia which is given by Rudy means there is a hyperplasia of the basal cells in the epithelial layer. So it forms as a cholesteatoma. Okay. The third one, primary squamous metaplasia. It is given by Jacob-Sade. This is Jacob-Sade's theory. Like, you know, if you smoke frequently, your epithelium in the ciliated epithelium in the bronchi and your lung, it will become into squamous epithelium, which is called as metaplasia, right? Metaplasia is nothing but changing of one epithelium into another one, right? That is called as metaplasia, right? So here also, due to some repeated infection, whatever the cause, okay? So this epithelium metaplasia into some other keratinized squamous epithelium. Okay, it might be due to repeated infections. Okay, so it can be following a otitis media with effusion also. Okay, so basically Jacob-Sade says it is a metaplasia, means changing of one epithelium into another epithelium takes place, so it leads to cholesteatoma. So secondary acquired, this is for secondary acquired cholesteatoma. Here the secondary squamous metaplasia. Again, the Jacob-Sade says that here the transformation of middle ear mucosa into squamous epithelium, again here due to repeated infections. Okay, secondarily, primarily here might be that is due to a secondary infection, but here the repeated infections are very well noted. So here the cause is very well known. So due to repeated infections, again here there is a metaplasia of the epithelium, right? And the next one is epithelial migration. So the epithelium from the pre-existing perforation in the tympanic membrane, there is a epithelium of external canal, it migrates into middle ear and it forms a cholesteatoma. See, the epithelium in the external canal is squamous epithelium, so it goes into middle ear. So the squamous epithelium in the middle ear is a cholesteatoma, right? So as simple as that. So tertiary or post-traumatic, this is very less common and you need not to bother about this. Here the epithelial entrapment in the fracture line, and again the ingrowth of epithelium through a fracture line and traumatic implantation of the epithelium. For example, if you do a surgery, if you are putting a skin into the middle ear, you are implanting a skin into the wrong place. Okay, that epithelium they entrap in the middle ear and it causes cholesteatoma. So what are the pathological changes you note in the unsafe CSOM? For example, in a simple word, if you see any of these, you should label it as unsafe CSOM. One is marginal or attic perforation. In a case of tubotympanic, it is central perforation, right? But in a case of this unsafe CSOM or squamous CSOM, or you can call as atticoantral disease, if you see a marginal perforation or an attic perforation, it is labeled as unsafe. And if there is a retraction pocket of the attic region or posterior superior retraction pocket, you can label it as unsafe CSOM. And cholesteatoma flakes, ossicular destructions. If you don't see a ossicle during your examination under microscope, you can label it as unsafe CSOM. Middle ear mucosa, it should be very red polypoid velvety edematous mucosa. You know, the polyp also red fleshy polyp. Osteoitis and granulation tissue formation is a hallmark of the disease. Because of the osteoitis, there is a necrosis of the bone. That's why you will be having a fishy bone. I mean, fishy odor in the ear canal. You will have a rotten fish smell. Okay, very bad smell, foul smelling, offensive smell. And you can see mastoid bone erosions and sclerosis of the mastoid bone. These are all pathological changes you should note in the exam. So how a patient presents to you? Always a ear discharge which is scanty. Scanty means little bit. Purulent. continuous. With the treatment also he will be having ear discharge. Okay, this is very important. And foul smelling, remember foul smell, and blood stain discharge. These are all the hallmark of the disease. And hearing loss, it can be conductive and sensory neural hearing loss means the disease process may damage the lateral semicircular canal and it causes or it may damage the round window. You will be having a sensory neural hearing loss. And tympanic membrane perforation, it should be marginal or attic, and you will be having a attic or posterior superior retraction pocket, and you can see a cholesterol flakes. And oral polyp, osteitis, and you can find a granulation tissue also. I'll show one. Can you see this attic perforation? Yeah, attic perforation, you should note it as unsafe CSOM. Can you see attic cholesterol flakes in the attic? Here? Yeah. And attic erosion, can you see here erosion of the attic? And can you see a reddy fleshy polyp in the pars tensa posterior superior region? And can you see a attoatticotomy, means the every bone. Here the one term is there, scutum, S-C-U-T-U-M, scutum. Scutum means outer attic wall. So erosion of the scutum or erosion of the outer attic wall means the wall in front of the attic region. Erosion is hallmark of unsafe CSOM. So you can see attoatticotomy means there is a total destruction. Okay, attic is wide open. See, can you see the posterior superior retraction pocket of the tympanic membrane? Here again you can see a posterior superior retraction pocket which wrapping the ossicles here, right? Can you see a cholesterol with high jugular bulb? You can see all the cholesterol flakes. Can you see a posterior retraction pocket with, you can see the facial nerve, exposed facial nerve here. Okay. So you can suspect a complication if the patient comes to you with the following symptoms. That is like severe ear pain, painful swelling around the ear, that is mastoiditis, vertigo, nausea, vomiting in a case of intracranial and temporal complications, headache, blurred vision, projectile vomitings, fever, neck rigidity, irritability, drowsiness, facial asymmetry, headache, retroorbital pain, and ataxia, balance disorders. If any patient comes to you with the following features, you should suspect a complication of the CSOM. What are the complications? Later you can know. Okay. Right. Can you see in these two diagrams there is a sputum erosion with the cholesterol flakes in the attic region with the tympanic membrane, or the pars flaccida is retracted. So how a feature, how a discharge, or how the disease presents? Yes. Discharge in a case of tubotympanic disease, it is profuse, mucoid and odorless. Okay. And in a case of atticoantral, that is scanty, purulent and foul smell. Foul smell is the differentiating point. In a case of tubotympanic disease, the perforation will be central. In atticoantral, the name suggests it is either attic or marginal perforation. Granulations in a case of tubotympanic disease, they are very uncommon, very less or uncommon, and in a case of atticoantral, that is very common. Cholesteatoma 100% absent in a case of tubotympanic disease, and they are most of the times they are present with atticoantral disease. Polyp is pale in a case of tubotympanic and red fleshy in a case of atticoantral. Complications are very rare in a case of tubotympanic disease and very common in a case of atticoantral disease. Audiogram shows mild to moderate conductive hearing loss. In a case of atticoantral disease, it is conductive or mixed. Mixed means either conductive plus sensory neural hearing loss also. Sometimes here I want to tell you one important point. This cholesterol sacs, though it erodes the bone, it may bridge between the ossicles. Okay, for example, incus is eroded, but this cholesterol sac is between the malleus and the stapes, and it conducts the sound. Okay, at that time patient might be hearing very well. He is called as cholesteatoma hearer. Okay, if you remove the disease, he may not hear. So in a case of sometimes the hearing loss may not be there. Why? Because the term called as cholesteatoma hearer. The cholesteatoma, which is bridged in between these two ossicles or between the middle ear, it transmits the sound. Okay. So what are the investigations? How you proceed? Examination under the microscope is must, and ear discharge you should take out for swab for culture sensitivity. Pure tone audiometry, you should document how much hearing loss is there, and X-ray mastoids, how the dural plate and how the sinus plate. Okay, CT scan for the plan for the surgery and to look after the complications. What are the advantages of microscope? It confirms the otoscopic findings and how the margins of the perforation you can look, and whether you can check for cholesteatoma and granulations, adhesions and tympanosclerosis, and you can assess the ossicular chain integrity, and you can collect the discharge. The most important advantage of the microscope is you can put the microscope in front of the ear and your both hands are free to do any maneuver over the ear. Okay. With the otoscope or with the endoscope, you should hold the endoscope or otoscope with one hand, and only one hand is there to do any procedure, right? X-ray mastoids. Can you see the above red line? Above line is, see the horizontal line. Above one is for, this is dural plate, and the below one is for, this is sinus plate. You should look after any erosion of these plates. If it erodes, you might be likely get a complication. Okay. So what are the uses of X-ray mastoid? You can see the type of pneumatization, the position of the dural and sinus plate, and the pneumatization is three types: cellular, diploic and sclerotic. Cellular is most common, means most cells are filled with air, and diploic is few cells are filled with air and few cells are sclerotic. Sclerotic means everything is filled with bone. You can see whether it is a cholesteatoma or not, and you can see bone destructions, and you can see how the mastoid cavity is. See this X-ray, see you can see a very good cellular mastoid. The mastoid is very cellular, that's why it is very black, which is filled with air. Here diploic, few black air cells and few white cells means sclerotic, so both cells are. You can see everything is white. This is external artery canal and everything is white color, so it is sclerotic mastoid. Attic region, can you see the arrow mark shows there is a erosion of the attic bone, and you can see in the X-ray. So if there is a wide cavity in the mastoid, so these are the differential diagnoses which is they usually ask in the pre-PG entrance exam. One is cholesteatoma, it causes erosion. Second one is a very large post-mastoidectomy cavity. Third one is tuberculosis. Fourth one is coalescent mastoiditis. And next malignancy and eosinophilic granuloma and megaantromen, large emissary veins, which also mimic as mastoid. Here you can see in the CT scan posterior canal wall erosion, you can identify. Here mastoid cholesteatoma, the arrow mark shows a cholesteatoma in the mastoid region. You can compare with the opposite. Okay, always you should compare with the opposite. See again the axial cut of the cholesteatoma. The other side there is ice cream cone appearance of the ossicles you can present. You can have to your left side there are no ossicles, means erosion of the ossicles. TEGMEN. TEGMEN means, what is TEGMEN? TEGMEN means the bone between the cranial cavity and the ear. See here the TEGMEN is eroded and the ear cavity is communicated with the brain, isn't it? So the infection will go easily from the ear to brain, and you will be having a wide variety of complications. So you can see here TEGMEN erosion. So you can plan what to do in the surgery also. You can decide with the CT scan. So treatment, medical treatment or conservative management is always a least bothered. You will never have a relief with the medical treatment. So, but it is for only those who can come regular follow-up, those who are not fit for the surgery. For example, a patient, elderly patient who is 80-85 years age, okay, he is not fit for general anesthesia. So in those cases you cannot do surgery. You can do a surgery under local anesthesia, but the surgery itself is a 5 to 6 hours long surgery. You cannot do under local anesthesia. And the early disease, if he wants to postpone the surgery for some time, you can. Okay, with the frequent suctions and a topical ear drops, you can use, but it is the ultimate treatment is surgery only. The surgical options are, there are two types of surgery. One is canal wall down surgery, one is canal wall up surgery. The canal wall down surgery means atticoantrostomy. Attic means attic region, antrostomy means mastoid antrum. You should open these two: modified radical mastoidectomy and radical mastoidectomy. Canal wall up surgery means combined approach tympanoplasty. The surgical treatment of the cholestoatoma or surgical treatment of the atticoantral disease itself a very big topic. I will explain you each canal wall down surgery, what is canal wall up surgery, what is radical mastoid. All these terminology I will explain you with a separate PowerPoint. For this class you should remember canal wall down, canal wall up. Again, canal wall down as atticoantrostomy, modified radical mastoidectomy, radical mastoidectomy. Canal wall up means combined approach tympanoplasty. Canal wall down means the posterior canal wall you should lower. Canal wall up you should not lower. You need not to lower. So in this class you remember the terminology itself. You cannot do a tympanoplasty, right? The surgical treatment for atticoantral disease is either canal wall down or canal wall up. So what is this surgery mean for and how you perform these surgeries, I will explain in a separate class. For this class you remember the names itself. Thank you very much.